to the presentation, so the topic allotted to me was the histological variants of papillary thyroid cancer. It's one of the fascinating aspects of the entire endocrine surgery scenario. Very interesting topic because it shows the vivacity and also the protein nature of spectrum of so many cancers. That's why it is said that papillary thyroid cancer is the prototype of entire oncology, because so many oncological aspects of thyroid cancer forms as a prototype, as a template, as a benchmark for all the cancers put together in the body, because it covers almost all topics. So it's such an interesting topic, and the histological variant is further fascinating. So next. So now, as all of you know, the classical papillary thyroid cancer features are the arborizing true papillary projections, true in the sense presence of vascular core, fibrovascular core in the papilla lumen, and the samoma bodies, which is also called calcospheroids, which are necrotized tips of the cells, and the main landmarks are the nuclear features, the presence of ground glass optically clear, also called as orphan annii nucleus. In fact, it's an artifact on formal fixation. Actually, there's nothing pathological significance otherwise. Longitudinal nuclear grooves, which is due to folding of the nuclear membrane, nuclear pseudo inclusions, cytoplasmic protrusions, and a cup-shaped nucleus, and nuclear crowding, and very scarce mitosis because they are very low-grade tumors. Next. So as you can see, the few pictures of classical PTC, the intranuclear cytoplasmic inclusion, longitudinal nuclear grooves, ground glass nuclei. Next. The arborizing papillae, you can see the optically clear nuclei. Yeah, ground glass nuclei. Then the pseudo inclusions also you can see the in classical PTC. The arrangement is irregular follicles with these characteristic nuclear features with plenty of colloid, bubblegum colloid. Next, yeah. So here sometimes the follicles are irregular with mixed with micropapillae and pseudopapillae, but the nuclear features are the defining factors in any variant. So one has to remember that. Next. Now, this is very important slide. Basically, we can categorize histological variants of papillary thyroid cancer based on the growth patterns, such as papillary, follicular, macrofollicular, solid, insular, trabecular, mixed, and the two underlined ones I will cover a little later, NAFTP and HTT. Based on cell types, it can be further divided into tall cell variant, columnar cell, oncocytic, and clear cell. Based on the stromal reaction pattern, it is diffuse sclerosing, nodular fasciitis like. Yeah, coming to the next. These variants are basically not mutually exclusive. Single tumor may have many features, more than one variant. So that is another interesting fact. The tumor is usually dominated by one particular subtype. So that's how we categorize into that variant. Next. So now this you can see the classification of WHO classification of the tumors. Same thing repeated, but based on the prognosis, you can see the little bad prognostic things are the tall cell variant, columnar cell variant, diffuse sclerosing, and those things, and solid variant. Basically the neutral prognostic things are follicular variant, which is one of the commonest thing, the oxyphilic variant, Warthin like, and of course I'll come later. Next. The good prognosis one is papillary microcarcinoma. Now coming to the tall cell variant, basically these are nothing but it is described by Hazard and Hack 1976. So usually occurs in older age groups 50 plus. Here basically the the definition is 30% of cells should have the height of the follicular cell should be more than twice of that of the width. So that is the definition of the tall cell. They occupy up to around 10% of the PTCs. Next. So these are the pictures. You can see the classical variant pictures with branching papillae, but the nucleus, the cells are very tall, as you can see. Next. Next. Next slide, please.
Sir, 1 minute. I think because of the big file is getting.
Yeah, it's a very large file actually. Previous one. Yeah, this one. So here left side is the classical PTC arranged in follicular and papillary pattern. Here you can see the characteristic eosinophilic cytoplasm with basally located nucleus. Because of the tall cell, in otherwise normal classical variant, the nucleus is central location usually, but here in tall cell it is basal in location because of the tall cell and more cytoplasm. Next. Coming to the biological nature, so basically they are aggressive tumors with high recurrence rates. They tend to dedifferentiate to anaplastic or poorly differentiated variants more frequently. Even the cervical lymphadenopathy rate is very high, up to 57%. Extrathyroidal extension is also very high. The chances of distant metastasis and tumor-related mortality is around 16%, 5-year survival rate. So that's how this is one of the bad prognostic variant of PTC. Next. The treatment is obviously total thyroidectomy. There is no question of anything less than total thyroidectomy. And the CCLND is to be added to this. And mostly it is in few studies it is shown that use of empirical use of adjuvant radioiodine therapy will definitely increase the survival benefit. Even basically we should have low threshold to use the adjuvant therapies in this scenario, tall cell variant. So that is the take home message. Yeah. Next, yep. So these are just noting the statistics. So as you can see in multivariate analysis, all these prognostic factors are significant, such as tumor size, capsular extension, extracapsular extension, lymph node presence, recurrence rate, and distant metastasis, and all those things. Next. Yeah, next, coming to columnar cell, here you can see there are less intense cytoplasmic staining. That's why it gives a very clear, relatively clear appearance, the entire cell cytoplasm. And because of this, there is also pseudostratification of the nucleoli. And the nucleus is usually supranuclear or subnuclear vacuolation will be there. And usually it is confused with many other pathologies. So that's why immunoreactivity with thyroglobulin is often used to confirm the diagnosis of columnar cell variant. Yeah, next. So again, it goes in the similar lines of tall cell variant. So extrathyroidal extension rate is very high. Cervical lymphadenopathy rate is around 50%, near to the tall cell variant. And some of the studies showed that the recurrence rate is very high, up to 40%, around 30% of the distant metastasis rate. But of course, they are far less frequent than the tall cell variant. Next. They are again they occur in a wide range compared to tall cell variant. The treatment is again total thyroidectomy with the liberal use of the adjuvant therapy. Next. Yeah, next. Next. So coming to the diffuse sclerosing variant, this is another very interesting subtype. Here there is diffuse involvement of this thing with vague nodularity and extensive sclerosis. So that's why it gives a very hard to handle it, and it's very hard in the consistency, macroscopically also. because of the dense lymphocytic infiltration also, and presence of numerous seminal bodies also leads to calcification. So you can see the presence of sclerosis, the presence of dense lymphocytic infiltration, the presence of calcospheroids or seminal bodies, all this leads to very hard nodule in this diffuse sclerosing variant. And there are only scattered islands of PTC with squamous metaplasia is another salient feature of this malignancy. This leads to ascended positivity in immunohistochemistry. Yeah, next. The another unique feature of this diffuse sclerosing variant is they occur most commonly in, it has been seen in by Nikiforov in after Chernobyl accident, nuclear disaster. So up to 30% of the people, children who contracted this thyroid malignancy after this accident had diffuse sclerosing variant, and cervical lymphadenopathy rate is very high. Again, the extrathyroidal extension, all these things are high, aggressive nature, high grade. Again, the treatment is aggressive with total therapy and liberal use of adjuvant therapy in the form of radiotherapy and radioiodine therapy, and also EBRT. Next. So this is another rare type. It's a diffuse follicular variant. So here, instead of sclerosis, the follicular pattern dominates with, but there is absence of fibrosis. Next. So again, these are whatever we are covering subsequently 3-4 slides. They are very rare variants, but all of them are very aggressive with high lymph node rate. But one good thing, because of the presence of follicular nature, it has some affinity towards radioactive iodine. So radioactive iodine acts very well in this variant. So that's one only good aspect about this variant. Next. So this is trabecular variant. Presence of cuboidal or columnar cells oriented perpendicularly in the form of trabecula. Again, this is biologically aggressive with poor prognosis. This solid variant is again, this was also seen in children exposed to ionizing irradiation in the head and neck area, and also after the nuclear accidents in Chernobyl. And 50% of solid growth with no tumor necrosis, but vascular and extra thyroid invasion is very high with very less favorable prognosis. So these are, but here whenever we are in doubt, the immuno reactivity with thyroglobulin will settle the issue. Next. So this is a poorly differentiated or dedifferentiated variety, which is insular variant. Very poorly differentiated tumor. We have quite a few publications. I have studied extensively in this, both in SGBG and post SGBG. So presence of poorly differentiated areas with solid trabecular variants and also insular variants. Again, this very poor prognosis, of course, but the prognosis is in between differentiated thyroid cancer routine and anaplastic, slightly better than anaplastic. Next. Here there are solid clusters of cells with high propensity for lymph nodes and distant metastasis. Next. Yeah, these are all poor prognosis studies. Next. These are all survival curves which show south trend, downward trend. Yeah. Next. Now, yeah, coming to better variants in terms of prognosis. So follicular variant first. This is the classical variant is the commonest. The next common is the follicular variant. Here there are no papillary projections, but follicular arrangement is seen, but the same nuclear features and other histological features. Next. Next. So these are the clinical pathological profile is almost similar to the classical variant. As you can see, the statistical significance is not significant when you compare the classical versus the follicular variant. In most of the these things, except maybe in the extrathyroidal extension. All other parameters like multifocality, lymphovascular infiltration, everything is static. The difference is not statistically significant. Yeah, next. The surgical treatment, again, the comparison you can see, the right side column itself will speak a lot about the behavior. It's similar to classical variant of PTC, treatment wise and prognosis wise, both the therapy and its response to the therapy. Even the survival curve is also similar. Yeah, next. Basically now, the off late, in the follicular variant, there are again some types. There is little confusion here because there are encapsulated, non-invasive variants and also invasive and poorly encapsulated variants. So here, to settle the issue, recently the term NIFTP has been introduced, that is non-invasive follicular neoplasm of thyroid with papillary nuclear-like features. So this is, previously it is FEPTC, but this non-invasive, non-encapsulated variant is called NIFTP. One has to remember this itself may be a question for the residents. So here, usually the genetics plays a role. Usually a follicular variant has RAS mutations more common, but to label it as PTC, the presence of BRAF or RET PTC or TERT mutations will settle the issue. Well, of course, I'll cover this later in more detail. Next. See, this is the criteria for NFTP. It's a very good recent criterion. Basically, it should be encapsulated nodule with clear demarcated capsule. The follicular growth pattern should be there with no well-formed papillae at all. No true papillae. No subamoeba bodies should be present. Or even if other variants are present, it should be less than 30% component of the PTC variants. The nuclear score should be maximum 2 to 3. More than 3, we should go do the genetic testing. That is the recommendation. Nuclear score should be lesser. No capsular vascular invasion, no tumor necrosis, no high mitotic activity. So these will these are the primary criteria to label it as NIFTP. This is very important slide. And also the secondary criteria is lack of BRAF V600E mutation, because the presence of it will label it as PTC. Yeah, next. Yeah, now the oxyphilic variant, now we are going to the rarer variants in the better prognosis group. So it is a classical nuclear features with, it may be partially papillary and partially follicular nature, and encapsulated collection of Hurthal cells, large polygonal cells with fine eosinophilic granular granular cytoplasm and hyperchromatic nuclei. So this is the salient feature. Yeah, next. Now coming to these rare tumors, of course we'll cover it so one slide after the other very briefly. Next. So this Warthin tumor-like variant is very rare. It resembles Warthin tumor of salivary gland with lymphoplasmacytic infiltrate, and cells have either oxyphilic or tall cell appearance. It is more frequently associated with presence of concomitant Hashimoto's thyroiditis. Mostly autoimmune diseases coincide. Next. The clear cell variant is very rare, both papillary and follicular may be present. These are all anecdotal and few case reports. So we don't have much information about these things except for academic interests. We are studying them for academic interests. That's it. Next. Macrofollicular variant, wherein the size of the follicle should be more than 250 microns, occupying more than 50% of cross-section area of a slide. It can frequently progress into anaplastic cancer. Next. The cribriform is another interesting feature. There's a lot of interest generated in this because of certain features. Cribriform variant, the form of interspersed squamous islands will be there. These are called morules. They're closely packed follicles and papillae or label trabeculae. The lumen is devoid of colloid. They are chromatin-rich cuboidal and columnar nucleus. Now, the cribriform variant has been found to be very frequently associated with FAP, that is familial adenomatous polyposis, that's Gardner's syndrome. Next. So now this, otherwise it's very uncommon, but it is very common in Gardner syndrome. It occurs in younger age group. The somatic mutation is on exon 3. Next. We are going to other features. The papillary carcinoma with lipomatous stroma. This is another rare variant with interspersed adipocytes. Next. Another very rare variant is with exuberant nodular fasciitis-like stroma, very hard with sclerotic fibromyxoid matrix. Next. Variant with spindle cell metaplasia. Again, this is of academic interest. Now coming to very good prognostic group. This is papillary microcarcinoma. This case otherwise called as a latent PTC, which against occult PTC. They are usually incidentally found in autopsy or surgical specimen more often. Very rarely we diagnose and operate it because they are less than 1 centimeter size. Otherwise, they get presented as thyroid incidentuloma and they are worked up. Next. So you can see the classical features will be there, but it will be very small nodule. More often, this is presence of multifocality. In the presence of multifocality, most of these foci are micropapillary carcinoma foci. That is the importance of this one. Architecture is similar. Next. More often, the papillary microcarcinoma is one of the most very good prognostic group. Nothing will happen with that. But rarely it has been found in 1.6% against distant metastasis, sometimes lymphadenopathy. So sometimes they behave aggressively, but there are no reliable preoperative markers to decide on its aggressive nature as of now. So we tend to treat it as a very low or benign natured cancer. That's it as of now. Yeah, next. These are all very various studies which are showing very good survival rates of more than 95% 10-year survival rates. Next. The various studies, yeah. Continue. The previous slide. Yeah. Next slide. Yeah, this encapsulated follicular variant, this is another variant also called as Lindsay tumor. The predominantly follicular pattern. They're characterized by nuclear features of this, but usually it can be confused with follicular adenoma or colloid nodule, but the nuclear features will differentiate this. Next. Okay. This encapsulated variant here, there are again criteria, because we need criteria. Otherwise, they tend to get underdiagnosed or overdiagnosed and leads to distortion of the data and also the reporting all over. So that's why we need uniform criteria all over for comparison and for meta-analysis and multicentric studies. The nucleus are ovoid in this crowded overlapped nuclei with pale chromatin. Of course, samabomide is present. Minor criteria are almost similar to the classic PTC. These are the things. Yeah. Next. These are various comparisons showing same thing, reflecting the prognostic nature of the various parameters of variants. Next. Next. Now, in survival analysis, following factors have been found very significant overall. This is the overall picture of the various subvariants. The histological grade, mitotic frequency, and the S phase cell fraction. In cell division also G2 M phase, metaphase fractions, they are statistically significant in the cellular studies. In multivariate analysis, the independent prognostic factors have been the tumor size and the histological grade. subclassifications, they are not found to be significant. Next. Now, again, this is just a level 4, level 5 suggestion. So these variants require total thyroidectomy, neck dissection for positivity. That is tall cell variant, columnar cell variant, diffuse sclerosing, insular variant, and also the HCC will Hurthl cell. So other types, few are anecdotal case reports, and others have good prognosis. So they may be treated with hemithyroidectomy or even follow-up also. So these variants require aggressive therapy in general. Okay, next. Now coming to just this is for academic interest. I have covered this. This may not find as of today, as on today, this may not find place in this presentation, but I have deliberately included because of historical interest and academic interest. The hyalinizing trabecular adenoma or tumor. Presently, previously it was called hyalinizing trabecular adenoma. Even before that, it was called as papillary adenoma. But presently it is called HTT, that is trabecular tumor, to remove the term adenoma. The differential diagnosis is papillary thyroid carcinoma or MTC because of the histological features. Here will be hyalinizing the trabecular pattern of arrangement with intermediate islands of hyaline stroma. Here again the differentiating feature is the classical PTC histopathology features are not present. That is the thing. That is the nuclear features are not present. None of the PTC nuclear features. The treatment is total thyroidectomy. It's basically a benign tumor. But here, for genetic interest, the previous slide, the genetic interest, it has been found that it has GLIS gene 3 positivity. If at all we find BRAF or RET-PTs or TET mutations, then the diagnosis will change to papillary cancer carcinoma. But if these are negative but GLIS3 positivity is present, it is labeled as HTT. Next. This is very important slide which I deliberately made. So what are the genetic signatures for these histological variants of PTC? Of course, it is not as well established and as not as robust as in MTC, because the genetics in familial MTC is very well established up to the level of codon and subcodon level. Even the codon based stratification of treatment and prognostication can be done. But for these histological variants in PTC, still we are in stage of infancy with regards to genetics. But a lot of research is being conducted and people are doing to do all the 5 omics studies, that is transcriptome, genome, proteomics, transcriptome, and all these things. Here you can see in general, to summarize, in FEPTs, that is follicular variant, RAS mutations are more common. In classical PTC, BRAF mutation is more common, around 50%. In anaplastic, it is P53. And again, the PTC tall cell variant, it has been found TET mutation is more common. RET-PTC is more commonly seen. RET-PTC rearrangements are seen in post-irradiation PTC, and the variant is usually diffuse sclerosing or solid cell variant. And APC, that is adenopatous polyposis coli gene, in cribriform modular variant in relation with Gardner syndrome. PTN mutation in classical PTC associated with Cowden syndrome. So these are the in general relatively better established and known genetic signatures of these histological variants. Next. Now coming to one of the study which I recently published along with Sabha is also there. So this is Annals of Medicine Surgery I have published. So I have studied compared genetics. This is somatic mutations in adenoma and also papillary carcinoma. We found homozygous mutations in NR. Of course, RAS has 3 subcategories, as you know, NK and HRAS. We found only NRAS mutation gene in 36% of benign thyroid adenomas, but in 7% of PTC cases, statistically significant. And homozygous BRAF mutations were found in 52% of PTC cases. So these are the genetic point mutations which we found. And of course, recently I have conducted along with one collaboration NGS study. The results I need to publish because there's a lot of data extracted out of this NGS. I have to sort out because are more than 500 to 1,000 genes have been studied. It has 12 subgroups and also 5 subvariants. And because the algorithmic analysis of next generation sequencing studies the point mutations, also substitutions, deletions, and also replacements. Next. Now the conclusions. The histological variants of PTC, it has relatively very low incidence variants in general. There is a lot of discrepancies in diagnostic definitions. Most of the reports are case reported in small series. Aggressive variants usually have extrathyroidal invasion, nodal metastasis recurrence, and metastasis rate up to 30 to 50% compared to the classical and follicular variant. Next. Surgery is the mainstay, that is total thyroidectomy with en bloc resection of the lymph nodes, usually therapeutic lymph node dissection. No need for prophylactic. In spite of these variants, unlike MTC, we don't need therapeutic lymph node dissection. Only we don't need prophylactic lymph node dissection. Usually, therapeutic lymph node dissection suffices with the present data which we know. Now, radioiodine ablation, only in follicular variant it has good response because of better differentiation probably. The genetic stratification is the future according to me. That is for diagnosis, prognosis, treatment, and follow-up. We need a lot more data. Next. Yeah, thank you.